We talk about respiratory failure, pretty straightforward. It's oxygenation and ventilation, right? Either they're hypoxic because they're not oxygenating. That can be due for a number of things. That could be lack of oxygen, it could be the inability to use oxygen, it could be a physiological component where alveoli are damaged or not functioning. Then you have hypercapnia, right? It's that CO2 retention. So anything over 45, what we're considering hypercapnia. You come down here, your common causes, right? Two ones we're going to talk about today will be ARDS and neonatal respiratory distress syndrome. Pneumonia, kind of beat to death, right? We talked about bacterial pneumonia. We've talked about those fungal pneumonias, viral pneumonias. What is the most common pathogen for bacterial pneumonia, hospital or community acquired? Okay, what's the most common cause for walking pneumonia?
Mycoplasma.
All right, what if I have a little bit of vodka in here right there and I do this every morning, you guys just don't know it? Pennsylvania, you know what I'm talking about.
Oh, yeah.
Yeah. You would be the first person to threaten me with that, right? Acute lobar atelectasis. What is atelectasis? Collapse of those alveoli, right? So what can cause that?
Heat.
What's that? Heat. Start throwing some stuff out there. We're talking about, I want you guys to understand and kind of think about your patient's pathophysiology, not necessarily the words, like diseases, you're still juniors. That? Yeah, so we talk about after surgery, right? We want the patient to get up and walking, moving sooner than later, because if they're not, they get atelectasis because they're not breathing very deeply. Those lower lobes aren't getting recruited. Alveoli aren't opening, so they start to develop atelectasis. If I breathe 100% FiO2 for too long, could that cause atelectasis? Yeah, it flushes out all that nitrogen. The alveoli start collapsing. So I'm less concerned about you guys knowing like the words and disease patterns and everything else, but just think about it when you're looking at a patient, what's going on with this. If you have somebody sitting in bed, what are they at risk for? Right? If somebody at a hospital bed, we talk atelectasis, what else are they at risk for? DVT, if they're stuck in a hospital, what else?
Hospital acquired.
Yeah, nosocomial infections. Put all this together, like if you're looking at a nursing home patient or somebody who's bedridden, what else? If somebody just sitting on their back, laying down that way for too long. Ulcers, right? They start getting those pressure sores, tubular ulcers, where their heels, their hips, their shoulder blades. We're putting all that together. Cardiogenic pulmonary edema, what is that?
Heart failure.
Said what I said, but you said it a different way. But what is it though? Like, is it a heart attack? Is it the heart failure, right? The heart's not pumping, so fluid's backing up into the lungs, right? What about lung contusion? How you get that? Yeah, car accident probably the most common in the United States, right? They come in and you look out, they got bruising on their chest. Get an x-ray, maybe they have very flexible ribs, no ribs fractured. Does that mean the lungs aren't damaged? No, but if they have rib fractures, I'm definitely thinking there's some lung contusion. And that may not be presenting itself right away. That may be a 12 to 24 hours type presentation. So this kind of goes back to, you had your clinical correlation lecture yesterday. We talked about like your assessment and plan. Every time you need to have a follow-up, if you have something that makes your spidey senses go off, that you're like, this can go sideways very quickly, have a tighter shot group on having them follow up. Say, hey, I need you to follow up 24 hours, 48 hours. We want to prevent them from becoming hypoxic. Hypercapnia, COPD, asthma. Why would they have that in COPD?
Can't blow it off.
Yeah, chronic infection, they just start becoming, are they chronically hypercapnic? Yeah, they start going into respiratory failure over time, their body's just not able to compensate, so they may be living at hypercapnia, right? So they may not be, respiratory failure is not necessarily an acute process, it could be a chronic process too, where this is slowly going on, where their body is just failing and every day is kind of worse than the previous day. About drugs that cause respiratory depression. Yeah, it's hypercapnia, but what are some drugs that would cause that? Opiates, what else? Benzos, propofol. What about a paralytic? So this just happened last year at BAMC. The flight team was doing some training, the nurses were. And they gave each other IVs and they thought they were using training meds. And then they pushed a paralytic and the nurse couldn't wake up. Everybody was doing like sternal rubs, trying to figure it out, Viagra and stuff. And they realized they pulled like real paralytics and given it to her. So she ended up in the ER, intubated. She was fine long term. I don't think psychologically she'll probably ever be fine because she was just guest appeared on Dexter. Type things too, right? Paralytics. If I paralyze somebody because I'm doing a rapid sequence intubation, and I'm not bagging because I'm sitting there at the head of the bed, but I'm too focused on what somebody else is doing. I see that a lot in traumas where the person who's bagging is like, oh, cool, kind of see that ultrasound, and they're more focused on the person doing the fast exam, and they're not really bagging. You go, hey man, you got a bag? It's like 20 seconds go by, and they're like, oh yeah, here's a bag, or they get like half a breath. So CO2 starts rising, so like that. But neuromuscular respiratory disorders. Polio, we see a lot of that nowadays. Maybe South Georgia, right? Yay, we pay, man. You can go online and put betting odds. When's the next polio spike going to be? ALS could cause that, right? What are some other neuromuscular disorders? Yeah, myasthenia gravis. Guillain-Barré, right? How do you remember that one? Around the brain. Obesity, hypoventilation syndrome, we talked about that. What causes that?
Obesity. Fat.
They're sad because they're fat, and they're fat because they're sad, right? They're overweight, all that weight is pushing down on their chest, they can't breathe, and how do you make that diagnosis? They're fat. They're fat. Yeah, daytime hypercapnia, right? So during the day, they're just not breathing fast enough. And what are the two things that your body has that kind of tells you to breathe faster or you need to breathe?
Oxygen
The CO2, right? So if your CO2 is high, your lizard brain kicks in and says you need to breathe faster, blow it off. If your oxygen is too low, what does your body tell you?
Breathe more.
Breathe more, breathe faster, take deeper breaths, right? So think about all this stuff's a lot simpler if you kind of look at it that way versus trying to memorize every different disease pattern and things that you kind of categorize in what your body's trying to do. Remember that oxygen affinity curve, right? You're going to keep seeing this in phase 2, not necessarily in phase 2. I doubt a doctor's just going to pull out his pocket and be like, ha, show me this. But they may talk to you about it, but you're definitely going to see it in your senior semester. It's an important concept. So, hemoglobin gives up O2 in exchange for CO2, right? Hemoglobin has a higher affinity for oxygen or CO2?
CO2.
Are you sure about that? It's got a higher affinity for carbon monoxide. It actually has a higher affinity for oxygen than carbon dioxide. That's important to understand when we talk about why this matters. Right? So hypercapnic respiratory failure means their CO2 is too high, right? What would that be diagnosed, or what's the level that we're looking at? Higher than 45, right? Remember Rome, respiratory opposite. So they retain CO2, so what's their body doing right now, most likely? They're not breathing fast enough, they're not breathing deep enough, right? They're retaining that CO2. So that's going to drive their pH down, which now takes us to our oxygen affinity curve. Decreased pH is going to do what kind of shift? Right shift, right? And then left shift we're retaining on there. So with that right shift, decreasing ability to pick up new O2 in lungs because the hemoglobin's saying I don't need oxygen, the pH is low. So what's going to happen then, decreases the amount of O2 available over tissue over time because it's not picking up any and releasing it. Just hold on to that CO2 because now it doesn't want oxygen. So it's not picking it up when it goes back to lungs. So we have hypercapnia, then that's going to lead us to cellular hypoxia, right? If you have cellular hypoxia, oxygen is not getting to those cells, can't create it, and then what do they start doing? You start creating lactic acid, right? Because they're dying off and they're not doing it, they're anaerobic. So then what's that going to do for your acidosis, your pH? It's going to worsen it, right? So all this stuff is kind of feeding into each other. So that vicious cycle, that circling the drain. So they can present very similar, or they can present differently, right? Can you have hypoxemia without hypercapnia?
Yes.
Can You have hypercapnia without hypoxemia? You have them both at the same time? Right? So, where I diagnosed that PO2 is what, less than 60 for hypoxemia, hypercapnia, greater than 45. Then we look down here, so you kind of use these words correctly, especially in a clinical setting. If we see distress, we need to intervene, right? That's telling you that something's underlying that we need to get aggressive with it, especially pediatric patients. They're working harder. Something's not going on. Anybody ever heard the term air hunger? What is that?
Who's mom?
Yeah, it's like a psychological effect of like everybody's had it on a PT test, right? At the end of it, you're like trying to get breath. It's that feeling of you're not getting enough air, that's going on, you're suffocating. It could be anxiety, it could be physiological effect. But distress, that early warning, right? Failure is that patient now that is not able to compensate, right? So that could be acute process, that could be chronic. Chronic being classically COPD. Acute being, or acute failure, their airway is impeded, right? They've lost their airway, it's compromised. They're not able to move oxygen. Maybe they have smoke inhalation. They're not able to do that, and then ultimately that leads to arrest. You guys all taken you guys have to take CPR, BLS before you get into ICAP, right? You'll do it again. They always talk about prevention. Reality, does CPR work all that well for people once they've gotten to arrest? So we have a high success rate of bringing them back. Say the odds are not in your favor if you go into arrest, so we want to prevent arrest. So all this stuff is early interventions and preventing it from going into the red. So if we see green, we want to stop it there. Definitely want to stop it at yellow. We don't want to get to red. It's pretty straightforward, right? Generically, correct the underlying condition when possible, whether that's airway compromise, whether that's an opiate overdose, whether that's cardiogenic. We have to figure out what's that underlying cause and reverse it quickly. So provide O2 administration. Why do I say maintain SpO2 of 88 to 90? That's like our bare minimum, right? If a patient is chronically walking around like a COPD patient at 90%, do I want to try to aim for 100 in the ER? What could that do? So that could blunt their hypoxic drive, knock it out, because they're living at a higher CO2, so their body's kind of adjusted to this sense of high CO2 isn't a tool or a trigger anymore for me to breathe faster and harder. Hypoxia is, right? So if it goes below their baseline, they're going to breathe faster, harder to get their oxygen back up. If you knock them up to 100, kind of artificially, you're going to knock out that drive, which is then going to turn their CO2, because their CO2 hypercapnia is no longer a trigger for them. Right? It also create the Haldane effect, which is vasoconstriction, where your body, the hemoglobin, is unable to hold on to CO2 or retain it because it has a higher affinity for oxygen. So CO2 goes more into the tissues, further driving up their CO2 because the hemoglobin is just not doing that. It's picking up all that excess oxygen through into the system. Next lecture we're going to talk about is O2 administration and all these different devices. So unless otherwise noted, right, there was that one special circumstance when I said you put 100% FiO2 on that patient and you're trying to get them up, non-rebreather, regardless of what their stats say. So concerned about carbon monoxide poisoning, right? So inhalation, smoke inhalation, they do that. That pulse ox is not giving you a true reading because it's just reading hemoglobin saturation. So in that patient, you want to go for the big gun non-rebreather, 10 to 15 liters, start blowing that off. Otherwise, we want to start with the simplest device we can, right? So if I put a non-rebreather on a COPD patient, very quickly, I'm going to knock out their hypoxic drive and probably have to intubate them and put them on a ventilator. So if I can get by with a nasal cannula, maybe like 2 to 4 liters, that's going to be the better bet. Now, then we talk about mechanical ventilation, right? Is an ambu bag mechanical ventilation? Yeah, because you're breathing for the patient. That's all it really means, right? It's something the patient's not able to breathe, they're doing it for them. So it could be an ambu bag or it could be an actual mechanical ventilator. And kind of a common reason why we would put somebody on mechanical ventilation, loses airway patency. So we talked about smoke inhalation, they're at risk for losing their airway. What are some other things? Trauma? Yeah, trauma, aspiration, what else?
Mental status.
Asthma, what about pediatric patients? What are some disorders that we talked about? Epiglottitis, right, the vocal cords, the epiglottis inflames. So that may be reasons why you take somebody's airway. When I say take somebody's airway, that means you're intubating them, right? Loses self-respiratory drive, altered mental status. So what are some other things for that? Drugs, right? Opiate overdose, paralytics, sedatives, COPD, right? If I gave them all that oxygen, I knocked out their hypoxic drive, now they can't breathe on their own. They're taking these little guppy breaths, that could be it. Has poor or no response to supplemental O2, right? So that may be your ARDS patient that you're giving them 100% FiO2 and it's just not working. They're worsening in front of you because they had pneumonia, you didn't tell them to follow up, and now they're 2 weeks after that or a week after that, and they're worsening in front of you, and you have to consult them or refer them to the ER. And this is very open-ended. Prognosis is really that underlying disease. Narcan for opiate overdose. You know everybody can get Narcan at the pharmacy or at TRICARE? So even if you're not like a drug addict or whatever, you can just request it from the pharmacist. I didn't know that until a few weeks ago. So they'll give you the little nasal atomizer for Narcan if you want it, just to have in your car or your kit. COPD asthma, if we're doing good treatment and they're responding, they don't necessarily be intubated, and they'll be good as long as we are aggressive with that. And then ARDS associated with sepsis, right? So sepsis being what? What's that? Systemic, right? It's just full blown now. It's their whole body. They're kind of tanking, going downhill. We saw that a lot, especially during COVID, when these patients become septic, and then that would develop into ARDS. And then we would have these high mortality rates, and when we're dumping everything we can at them, ECMO, high frequency ventilation, all this stuff, and they still have a high mortality rate, 90%. Now we're getting into ARDS. So, kind of hinted at yesterday. Very straightforward. It's non-cardiogenic pulmonary edema with acute hypoxemia, respiratory failure. Typically 1 week of injury. Most cases it's 12 to 24 hours, right? So rapid pulmonary edema, what's that telling you?
Quick.
The lungs are getting saturated, right? And it's not because of the heart. There's some underlying feature. Quick history on this. Anybody know what else ARDS, before it was called ARDS, used to be called? What it was nicknamed? In World War II, it was called wet lung, right? So we were seeing that a lot in the Pacific, where people would get injured and kind of stuck there. We couldn't evacuate them. In like a day or two, sometimes a few days after, they would start developing these symptoms where they were drowning almost in their lungs. They couldn't be oxygenated. Then what was it called in Vietnam? I just think it's a cool Da Nang lung. Remember, imagine go to like the VA and you're like, I got the Da Nang lung. So why it was called Da Nang lung, specifically Da Nang instead of Saigon or anything like that, one of our major evacuation hospitals was in Da Nang. So as people got injured at battalion aid stations, they went to maybe the regimental aid station or like a MASH. Then they would come to Da Nang, and it was like a bigger hospital. And it would be like a day or two after the injury, which kind of ties in that 12 to 24 hours, right? So a day or two after injury, in Vietnam, they would come to Da Nang, and then they would start developing these symptoms. And there was a lot of research that came out before this was coined as ARDS. They nicknamed it Da Nang lung. By definition, 1 week of injury, typically 12 to 24 hours. And what is going on? What's causing that pulmonary edema and hypoxemia? Kind of two different things are happening at once. So the capillary cells and the alveoli cells are damaged. So if the capillary cells are damaged, what's going to happen? They're going to start just leaking fluid, right? Like a sieve, they're just going to start dumping it out. So that's going into the lungs. And then if my alveoli cells are damaged, what's that going to do? I'm not going to be able to produce surfactant, which is what's keeping my alveoli open against that surface tension and allow them to actually have gas exchange. So as that goes, we get that pulmonary edema because the increased vascular permeability of those damaged endothelial cells, the capillary cells, are just dumping out fluid. And then we're not able to keep those alveoli open, they keep collapsing because we're not making surfactant, which then leads us to hypoxemia, right? Common causes, we talked about with sepsis, diffusive pneumonia, right? They may have an underlying disease that you don't know about, right? So kind of the classic is if you don't get a good medical history, you may not know that, hey, I got seen at an urgent care when I was at the beach last week. They gave me a Z-Pack. They said I may have pneumonia. They didn't tell anybody, and and now they're presenting, and then that pneumonia maybe was atypical and wasn't responding to azithromycin, or maybe it was a different bug. Aspiration of gastric contents, right? We talked about that. That's polymicrobial, so it's going to be a lot of different bugs, and then the acidity of that can also damage the alveoli, damage the airway, ability to clear secretions. Trauma. We saw a lot of this, especially during global war and terrorism, where patients would get injured in Afghanistan or Iraq, stabilized, sent to the combat support hospital. And then we got really good at our evacuation. We were getting patients back to BAMC, Walter Reed, San Diego, Bethesda, within like 2 to 3 days of injury, right? Which is unheard of in any other previous war. They would come back here initially stable, and then they would start decompensating once they got stateside to the hospitals and they would develop hearts. Near drowning, I haven't seen a lot of that, honestly. Drug overdose, and then inhalation of smoke, corrosive gases. I think we see that higher in the military population just because of the work we do and the injury patterns, and kind of, we do a lot of vehicle mounted stuff. Speaking of that, did anybody see what happened in Ukraine this week? Very scary stuff. It's like the first documented surrendering of Russians to a Ukrainian drone. The Ukrainian drone rolled up, and it was like one of those little tank ones with a machine gun on it. And then 3 Russians come out of a building and put their hands up and start laying on the ground. And then the operator of the drone starts speaking Russian to them, and then you watch the video, and it's just like this drone going, and then there's 3 Russians walking behind it. Which, that doesn't get speaker factor. I don't know, man. Like, that's serious. I'm glad I'm retired, because if they try to call me up, big goose. Need one of you marksmen over here to help me out with that one, right? Don't need to hit an artery, just something, maybe give me a little limp, give me a little something with a cane. That ain't my fight. All right, so you don't have to notice the test on the left. So this is kind of a diagram that's showing you as the fluid increases at extravascular lung water, or the fluid in the lungs increases in its vascular permeability, that damage to the capillary cells increases. If those both increase, then our likelihood of severe ARDS is going to go up. And we'll kind of talk about mild, moderate ARDS using the Berlin criteria and why that matters. It's more so descriptive, so when you're talking to people, you can do that. And it may change our treatment plan depending on where you're at. And then this chart on the right, cardiogenic versus non-cardiogenic is a very important differentiation when it comes to this, right? So just because they have fluid in the lungs doesn't mean they have ARDS, right? It could be cardiogenic, heart failure, fluids backing up into the lungs, or ARDS, which is this acute process, right, which is non-cardiogenic. So things to know about this kind of differ out. The things I pick out on this, right? I look at the distribution of edema, especially on chest x-ray, right? So even or central, patchy or peripheral, what you're going to see is very characteristic of ours is they're going to start getting these patchy infiltrates, right? And then over time, they're going to start kind of going together, and over a few days, it's going to be the whole lung that's affected. Intermediately, you're also going to start seeing air bronchograms, right? Initially with ARDS, you're going to see a lot of them, and as time goes, you're going to see less and less of them because more and more of that tissue is being saturated and the alveoli are not working. So start shunting air to the areas that are actually working. Then over time, those areas may not stop working, and then eventually it's going to be both lungs. Another thing you're going to see to differentiate these two is going to be on that chest x-ray is the costovertebral angles, right, where the diaphragm and the chest wall come together. Pulmonary edema, it's not going to salvage them. You're going to get kind of a flat effect where it blunts those angles. With ARDS, it's going to reserve those angles, and you're going to see that. So that's another kind of characteristic. And the response to diuretics, where it doesn't. So if you have cardiogenic, right? If I give you diuretics because you have fluid overload, and it's wet lung, you're hearing crackles and wheezing. Is albuterol going to help that? No, they need diuretics. They need something to get that fluid off. So traditionally, if it's cardiogenic, in fact, you give some type of diuretic, it releases that fluid. Their respirations are going to improve. It's less labor. Versus if I gave that to ARDS, and I'm not telling you that that's you're not going to just give it to see if it works, but if I gave this to ARDS, diuretics, it probably wouldn't have much effect. You're still going to have that because it's a different process. So, history of lung injury. When we say history of a lung injury isn't like I punch somebody in the chest and now you have a lung injury, or I stab them. It's just something that happened. It could be trauma, it could be infectious. something along those lines. So history of that is very specific. Rapid onset of progressive and profound dyspnea, right? So most likely they're starting to develop ARDS and they're conscious with you. They're not going to be having organized speech. They're not going to be being able to clearly articulate themselves like I am right now, right? Because I'm so clear. So that may be a history that you're getting from the family or from caretaker or from paramedics when they arrive. So if paramedics pick them up, you may have a different presentation by the time they get to the hospital. Then that marked hypoxemia, refractory to supplemental O2, right? So you're giving them O2 and it's just not improving. It keeps getting worse. You keep cranking up the FiO2. What I want you guys to think, oxygen is not just this benign thing that we give, right? There's a lot of side effects if I give too much oxygen. If I gave too much oxygen to a premature baby, what could happen? Yeah, so you could have premature retinopathy, right? I think Stevie Wonder, that's how he became blind. Too much oxygen given as a premature infant. Also cause oxygen toxicity, worsen their atelectasis. Use it when you need to, but don't just willy-nilly throw an oxygen at everybody and thinking it's benign. But as we see, the early exam, right? What is this kind of pointing out to you? What does that presentation look like? Is that respiratory distress or failure? Distress, borderline failure, right? They're hypoxic, a number of things, tachycardia, tachypnea, intercostal retractions. That patient comes in, I don't have a good history. My differential diagnosis is this big, right? It's all over the place because that can be a number of things. What you're going to see with this as it progresses is all those things are going to continue to worsen, right? Severe hypoxia, regardless of what oxygen you're given, they're going to start becoming confused. What is grunting kind of an indication of? Yeah, they're trying to recruit alveoli, trying to breathe, trying to get in there. It's kind of that late finding. Severe tachypnea, it's going to keep going up. So before I get PA school, I worked at the burn unit, right? And so at the burn unit, they're hypermetabolic because they're just burned, right? They're constantly doing that. So their heart rate is just like resting at 120, 140 for like weeks, months at a time. It kind of screwed me because I worked there for 3 years. And then I went to my rotations at Fort Benning in the ER there, and the patient's like 110. I'm like, that's not that bad. The ER doctor's like, are you insane? I was like, I mean, I've seen worse. But in my mind, I was so conditioned to patients just resting at 120, 140, that 110 didn't faze me anymore. So don't be that guy, right? So if you're seeing anything close enough to 100, you need to start getting concerned about some underlying disease. Then those 2 chest x-ray findings that we talked about, that spares the costophrenic angles, right? It flattens it out, and pulmonary edema, cardiogenic, and ARDS, you're going to preserve those angles. Air bronchograms, and I have some x-rays to show you, very unique finding that you're going to see on there. That's going to change over time. And this is a rapid, they become fluent. So you have these little patchy infiltrates, and then over time, matter of days, hours, they start combining together, and then you'll start seeing on the lungs. Then the Berlin criteria, this is how we're going to determine if it's mild, moderate, or severe. And that's simply PaO2 divided by FiO2. Mind turning lights off. Specifically the ones in this front. All right, so in this dark area right here, that's the air. This is where that fluid is starting to collect right here. It's kind of atypical on one side. And then here you're just seeing these non-specific infiltrates that are going to start combining. Is this patient on the left there, are they intubated? On the right. Kind of hard to tell on these.
Yeah, it looks like a crate.
This patient's actually trach, correct? Yeah. See that? Circle up here. So you shouldn't have to look for 2 placement on that because you can't really push those down any further for a trach. Right? So here's that progression over 48 hours, what we talked about yesterday, right? So the angles right here still preserved throughout. And then you're seeing some of the lower lobes, these infiltrates that are kind of non-specific. Maybe you're starting to get them up here. And as they progress, continue to worsen, right? It's starting to white out. You You can clearly see the cardiac silhouette on that first one. Second one, maybe looks like almost like the cardiac silhouette's getting bigger, but it's not. It's just that lung overlap. You're starting to see that infiltrates. And over here, can you even see the cardiac silhouette? The third one? No, but I can still see the angles. So that is characteristic of ARDS. Another thing, what are all these dark spots here? Those are those air bronchograms we talked about. So this is a lot of them right here. Very clear right here. Because these tissues still performing. That surrounding tissue, the alveoli are starting to collapse and fluids overloading it. So those aren't perfusing. So now they're down to that function of just these dark spots here. There's only part of the lung that are actually doing their job. So here's your Berlin criteria. So within 1 week of known clinical insult or new or worsening respiratory symptoms, right? So clinical insult being that lung injury, whether it's pneumonia, whether it's trauma, some underlying condition, smoke inhalation. And then bilateral capacities, right? So this isn't going to just be one lung typically, it's going to be both. You may start to see it progress in one lung, but over time, it's going to be both lungs. And then respiratory failure not fully explained by cardiac failure or fluid overload, right? So you've had a cardiologist in there, they did an echocardiogram, and they're like, nah man, the heart's good, it's pumping, it's doing what it needs to. Some specialist or some type of objective data that shows that, right? Then we come down here, it's mild, if it's less than, or greater than 200 and less than 300. Moderate is going to be greater than 100, less than 200, and severe is going to be less than 100. So you don't need to do these calculations of the tests. You just may need to know mild, moderate, severe, right? Understand those cutoff scores and what that's telling you about your patient. So management, this is like about the most simplified, very overview of ARDS treatment because it's a very complex condition when you treat these patients. Patients have very long stays in the ICU. They're not going to be recovering in 24 hours and getting discharged, right? But we want to, end of the day, the two most important goals is open those air spaces, right? Open those alveoli. There's a number of things we can do, and then get O2 into the lungs. We want to start getting that gas exchange. To do that, we need to figure out the underlying illness injury, right? If it's infectious, we need to figure out what is causing that infection. Sputum samples, blood cultures, sputum cultures, anything getting infectious disease involved. Especially in the military, right? We have different bugs in different parts of the world, right? So if they're getting evacuated from somewhere or you're in a different country, it's going to be different. So ID needs to know and be engaged. They're going to be intubated, put on mechanical ventilator, which we'll talk more about. But PEEP is positive end expiratory pressure. You guys remember me talking to you about CPAP? What do we use CPAP for? Sleep apnea, right? So continuous positive airway pressure. It's during inspiration, expiration. We're just basically keeping that baseline. But baseline is 0 pressure in your lungs. We bump up to 5 centimeters of water. So that's just going to be continuous. So it's basically keeping those airways open, keeping the alveoli open. PEEP is the same concept, but you can't do it by itself. So it's kind of like an add-on to a ventilator mode. What that is positive end expiratory pressure. So end of the breath, instead of that baseline going back down to 0, we put it to like 5, 10, 15, whatever it is. That additional pressure is going to help support and keep the alveoli open, right? So remember the disease pattern for this is collapsed alveoli, and then they have excess fluid in their lungs. So PEEP is going to help keep those alveoli open and help atelectasis. So you'll hear it in hospitals or when you're on your rotations that are trying to recruit. Recruiting is alveoli opening. So we give PEEP, that helps to recruit alveoli. There's other tools we can do to help recruit those. Supplemental O2 to maintain the SaO2 over 88 over 90. And then proning our patient. Anybody ever seen a prone patient? So all it is patients typically are on their back, right? That's how we sleep. This is where you flip them on their stomach. There's beds specially made. They have roto beds. If you're really interested in kind of how to do it expeditiously, you can go to the Prolonged Field Care Working Group, and they have videos, examples to do it. There are some risks associated with it. But what it's essentially doing is if you have that patient depend on their back for too long, things start to collect. You're not getting even distribution of blood. Air is not evenly distributing. So we flip them, prone them, put them on their stomach. Now that's opening up and allowing for recruiting. It's redistributing that blood, redistributing airflow, in the hopes that we're going to recruit the alveoli and help with that breathing. Prognosis, mortality rate is 30 to 40% within 2 weeks, right? And also, the big key factor to that is going to depend on comorbidities, right? Do they have something going on? Do they have an underlying heart condition where the pump is not working great? Underlying condition of, do they have sepsis, right? Do they have some weird pneumonia bug that we haven't seen that's not responding? Do they have MRSA that may not be responding to our typical bugs? And then what happens the longer a patient stays in the hospital? All that other stuff starts happening, right? DVTs, right? We start increasing. So if you like very complex problems and constantly being like bombarded when you think you're getting ahead, critical care is for you, right? It's very much a game of 1 step forward, 2 steps back, or 2 steps forward, 1 step back. You're constantly kind of going back and forth and kind of at the edges of medicine of pushing that and doing all the tools that you have. So enjoy that critical care maybe for you. This is an example of proning a patient, right? So what are these on their legs? And what do we have right here? Some type of line going on. They're on a ventilator. I can see the tube coming through right here, ventilator circuit. Doesn't mean they have to stay completely prone. Like I said, we had a patient at the burn unit. It was a 14-year-old girl. She didn't look 14. She looked like she was 20. She was a big old girl. Her house caught on fire near Corpus Christi, and she went back inside the house to get her dog. Got really bad inhalation injuries and developed severe ARDS. She survived, long story, but at one point we had her prone. We had a rotobed, so every 4 to 6 hours it rotated back and forth. It was an automatic bed. It was like on a big spindle that it would rotate it. Her CO2 for like 2 weeks was hovering in the 60s to 70s. So we were doing nitric oxide. We had a ventilator drilled up as high as we could go. At one point, she had 7 chest tubes in because every day she would blow more pneumos and her lungs were getting overinflated, trying to blow off all that CO2. She survived, and then they got a big lawsuit against PlayStation because it was a refurbished PlayStation that caused the fire. All right, neonatal respiratory distress syndrome. Anybody here ever work or spend time in NICU? I did that for 2 years and I hated it because the neonatal nurses are the best nurses, but they're the meanest nurses. If your kid's ever in a NICU, those are the nurses you want because they treat it like their own baby. They're very protective. They do a great job. If you're ever interested in that, it used to be kind of owned by nurse practitioners, but PAs have started kind of hollowing out their own niche and NICUs, and so now they have NICU fellowships outside the military. That's something you enjoy doing. But they also hear it called hyaline membrane disease. That was more of the classic description of this disease. Essentially what it is preterm infants, right? Preterm, we think in anything sooner than what? What's that? What's premature? So 37 weeks is typically our cutoff, and then you can kind of divide it down there. You can do subacute, you can do premature, like the youngest baby that is documented to survive is a 21-week-old baby that just happened in Iowa. The youngest I've ever taken care of was a 24-week, which is kind of the average NICU. 24 weeks about that cutoff, 23 weeks maybe. 21 weeks is nuts because that's the size of like, 21-week-old babies like this, right? So what's happening is their lungs are not developed. They don't have the structuring and they're not able to develop that surfactant to keep those alveoli open. So without those alveoli open and they keep getting atelectasis, what's happening is neutrophils accumulate, right? They start causing inflammation, which is then causing that pulmonary edema. Those capillaries are dumping out fluid on these patients, right? So exactly what you would suspect, right? Respiratory distress, tachypnea with cyanosis, that's that blue baby, right? They're not really able to actively gas exchange, so they're tachypnic trying, right? Nasal flaring, intercostal retraction, those accessory muscles, right? Those are signs of distress. You see that in a pediatric patient. Your mind should start blinking. You should be concerned about that patient. Get involved sooner than later. ABGs and SpO2 show hypoxemia. So what would be hypoxemia on an ABG? What would it be?
Less than that.
Would The SaO2 or the PaO2? PaO2 less than 60 for our diagnosis is hypoxemia. And then diffuse bilateral infiltrates with air bronchograms, just like ours, right? It's a very similar concept, except the underlying condition for this, or the underlying etiology, is just prematurity, right? So they're born too early, their lungs haven't completely developed, so they're not creating that alveoli, and the alveoli aren't very strong, so they're collapsing very easily. So, we talked about ground glass. What else would you see ground glass on X-ray on? What? If I say ground glass, does that just mean neonatal RDS? What? ILD, right? Some fibrosis. So what I was saying is that ground glass is not just necessarily fibrosis ILD, although it's strongly pushing you in there. You got to tie it with the history of the patient. Very unlikely that a premature baby has ILD or any type of fibrosis. Or maybe that 1 in a million that I don't know. But on the right, this is your moderate, so you're still seeing that ground glass. You're starting to see air bronchograms. These little specks right here, these are the air bronchograms that we're talking about. Right down there, that's actually the picture. Over here, air bronchograms, right? And then on the left, you're starting to see that advance, right? It's becoming more whited out. So on that moderate, you're starting to see a little bit in this left lung, but now you're starting to see it in the right and left. And on that severe, you're starting to see a lot more air bronchograms, right? All this dark tissue surrounded by this hazy, whited out tissue. That's where those alveoli are collapsing, the fluid overload from the capillary, right? They're putting too much fluid in their lungs and they're not keeping those alveoli open because they don't have enough surfactant. How do we prevent this? Right? So we give steroids to mom, which is good in the hopes of if you give it prematurely, that's going to kind of expedite the lung development. So you may see that in like your OB rotations or in the ER. Pregnant woman comes in, they're before their thing, right, low gestation age. They may give them steroids in the hopes that if this baby is born early, that they have a fighting chance because now we're kind of progressing their lungs a little bit quicker. Then positive airway pressure, so either PEEP or CPAP, right? Little babies will do CPAP, little nasal prongs on there, or they'll do PEEP. What you understand is you don't do PEEP by itself, right? CPAP you can do by itself, that's a mode. PEEP is an additional feature on a mechanical ventilator, right? So you breathe in for the patient, you can add PEEP, but you can't do PEEP by itself. Then you're going to give them surfactant, right? So you can nebulize it or put it directly in their ET tube. I've never nebulized it. But what it was is you would have your little premature baby, or my bottle, coffee. They have an ET tube, you put the surfactant in there, right? And then you would kind of rotate them to make sure it got in all the lobes and everything. You bag them throughout it, so you just kind of do this motion for the premature baby with that surfactant to get it all in there. Nebulizer, you can do that. It's just less common from my experience. And then you're continuing that ventilation surfactant to keep their SpO2 over 90. Their hospital stage is going to be kind of, the earlier they're born, the longer their hospital stay is going to be. But if you ever go over to BAMC down the hallway where the NICU is, where labor and delivery is, you'll see all the pictures of all the premature babies and then when they leave the hospital. Mortality, as long as the United States, right? If they're born outside the United States or a developed country, they have a high mortality rate. But specifically in the United States, we have a low mortality rate because we have a lot more NICUs around the country. NICUs are kind of rated like level 1 NICU is for like the super premature babies. BAMC is a level 1 NICU. Fort Hood has like a level 2 NICU, which they can take care of like probably 28 to 30 weeks, but they can't take care of the super premature. Some of those patients, you just have to get them to the right spots. But untreated, especially these undeveloped countries without this care, severe hypoxemia leads to rapid death, so high mortality rate. Any questions about this? All right, so let's take 10 and then we'll knock out the next class.
look at here, space to space. It's before where it should be. No, go look before. No.
That's 5 blocks. She's actually up because the kids.
I'm gonna do it. Right.
It's the same.
No, it's not. So that is that, but because that is the one block, it's in the
Because the guide for premature, it's normal QRS, but the guide for scale is narrow QRS, which is why I thought it was narrow. No, that's
it is narrow. That's why it's junction. How is that not?
no, I think yes, I agree with you. I think that's narrow, but if you look at the slides, it says premature functional is no peaks, normal.
Yeah, which is
But
narrow.
that's not normal.
That is narrow. So
That's narrow.
okay, so when you or F, it's not like it's not narrow, normal, wide. It's wide or narrow, meaning that narrow. Yeah, so like there's no issues. There's no issues with the QS being narrow. If it's wide, there's an issue. The wider you get, but when it comes to narrow, it's not narrow, wide.
They're both the same thing, except one happens before the other one happens after.
Yeah. So in this case, so yes. So if that
And
Q
there's no right?
so if that QRS,
Or if the peak goes down.
yeah. So here's the next thing. If that QRS, let's say, was right here that T is at, you would initially take escape, right? But here's the difference with that. When you have an escape rhythm, it changes the rhythm. Meaning that like the heart recognizes the SA node is not doing my job. It's doing its job, so now the next it has to do the job. So if that started here and then you started getting a brand new rhythm compared to what you had before, then it's escape. But if there's a gap and then you're still having the same rhythm, now you're thinking something like a sinus block, a sinus arrest, you get that new rhythm.
Is that why I got that little knock thing? Because it looks like that was supposed to be a
yeah, and that's telling you that's the biggest issue. But I think the issue if you can tell what the normal is supposed to be, mark the normal, and then add it to the abnormal to see is it too late. Yeah, that's all you have to do. But what I was saying is, don't let it just be greater than what the distance the normal distance is. Automatically continue to escape because an escape is the cause. That's the whole point of why it's called an escape. Something is taking over, so it's causing a new rhythm. So you're gonna have something that's different. So if they have an atrial escape, you see brand new rhythms. They're gonna look completely different than what you had. When you start getting to junctional escape, you'll have the full QRS either inverted or no QRS. And then the ventricle, you're gonna have no QRS or Y. But it's gonna look different if you have the full. Yeah. So in this case, because so this is premature, but like if that was just a little farther down, but it's still looking like that, then it's possibly not escape, but some type of block. Because the signal is taking too slow to get there, but still staying slow. Every week it's just like I can't wait to the weekend.
I texted you and then I was like,
I saw you texting me, and it was like 40 minutes. I saw it 40 minutes later. I was like, oh shit, I didn't put my phone.
and I found, I was like, I got to the side there.
It's supposed to be an escape.
No, this is a junction. So the reason,
But
so
she calls it junctional escape.
it changes. So the whole part of the escape. Okay, so the whole part the escape is so in your mind, equivalent escape to a change. If on the rhythm you see a rhythm and then it changes into a totally different rhythm on the same strip, that's
But then, how would I?
So-
It is functional because
Yes.
it has no,
correct.
and it's a narrow.
But because
Well, not narrow, normal.
yes,
Yes.
but it's not escaping from it. Because if you read it, it says you can escape from the normal science. It doesn't be like that. So at one point, it might have been normal science.
Because on the slide she says functional rhythm, but then they're all escape.
Wait, it's an escape. It's
And
a can.
it's just all, there's
So-
no difference.
Exactly.
It means,
So-
because it is before, it means something's going wrong, there's no, SA, involvement or AB, and then the junction is.
So junction
Oh, that's right, she did say that.
venture point when either one is not working, so now the ventricular myocytes have to do the work. Yes. And that's why
So
it's
they
so
can
hard.
only could be the rate.
It can be the right.
But no
But,
P.
yeah, but you could be like, oh, okay. If you looked at the multiple pieces and you're like, oh,
But it can also be the second rate.
That's right.
And
But they will be
But
fine
then you're
because
gonna
there's
see
no
the-
P, and there's no
yeah.
here.
So it,
so there's a couple of things pointing to
I
it.
think, I think one of the has I can't remember which one.
I haven't gone that far, don't.
Okay, I don't want to mess with you. I don't want to mess with you. So,
Wait, no, I did have a question.
I'll pull up
This one, okay, so this one is the premature blood. Wow.
that's a big apple. So you see that. So you have a normal going on. You have the URS, and then out of nowhere you have a URS and C.
Because I associate this with my left bumper right. It's just not in my soul.
So the reason why it's not a left bumper is because if this was a continuous monitor, you're gonna constantly see this one like this. Randomly a PVC and they're repeat like that when you have normal rhythm, and have no PVC. So just there's this irritable foci in the ventricle. So just out of nowhere, it's firing.
So if it's out of nowhere,
Yeah.
it's a PVC.
It's gonna be.
But it doesn't reset or it doesn't.
So it does reset, especially when it's isolated. So do you remember the RNC phenomenon and the running reset? So the issues you have with PVC is that once you start getting multiple of these at the same time, instead of it normal, start random PVC back to normal, you start getting on that PVC, another PVC, another PVC, another PVC. Once you simply get 4 and above, you get what's called run-up feedback. That's because it's turned into the and now you
Well, I thought it was more than 3.
I've done this more than
Okay.
3 or 4.
So if you just do the one,
Yeah, like if I even 1 to 2, but
And then,
but like
and then left,
if they're
left, bundle branch block, it's that same looking, but it's different.
yeah,
It's in,
you can and also
I wanna say 1,
it's also going to be more isolated. So I know we're on this one. I know which one it is. The final one. So that it's slightly different because it's so this right here is left on the right. So it's wider and it's you don't have that too. You don't have that. It also has it looks different than the PVC here. You're gonna see more of that. It's harder on the. So another thing, looking at here, is you see how with V2 having one negative of that R wave, well, not really R wave, you have like more prominent of an S wave. You don't have that. So, what's the normal progression that you want to do? You have small, big,
wait, small R, big S, and then flip.
yes. And here it's not, it's still staying big. And here it's, and yeah, before it should guy in a way more common are at this point. So that's why I can tell you, okay, that's more. I'm thinking because it's all messed up. Consistently, I'm thinking that one branching out. Because like I was saying, PBC, it's just going to be a random point on the rhythm unless it starts getting the right concept.
I don't know that one, bro. I was sitting there like,
That reminds me. It's grant, but it's different. It's not on my 2, it's on my 1, and 6 again. But
But it's consistent. So unless you're not going to have a emotion and then a random one. All of it's like butter brand. That actual butter brand. Because of seduction that says
it's only one, and it doesn't matter if it's only one random on any.
but that's just one random. Unlock like this. So basically, you're not going to see the PVC. You're not going to see a ton. It's not going to be like one, like one giant. It is. That's no lie.
Okay, so then how do I differentiate that from that from brand? Because here now I'm gonna have multiple in one, one and multiple in 6.
Because you're going to have it. You're going to have
It's like my need to was gonna be covered with all this.
you're being creative. And also try to certain things for feedback. Also feedback your output. Now we're
Wait, half? I thought we tagged you was like in and out all of this.
you may be. It's not going to be healthy. Like this.
See, but that's different. That does not look like.
No, it doesn't.
That's what I'm saying.
So what I'm saying is that yeah.
So one, any, just one. PVC. And one.
Alright, we ready, guys? Alright, we're going to talk about supplemental oxygen layers. Again, this is like a very wave top class. I'm not going to be going super in depth on mechanical ventilators. We're talking about like the main modes and kind of some of the settings if you find yourself in a situation to keep yourself out of trouble, but not enough to like provide even like care. That would be a months-long course. So I was going to teach you that. So we're just going to be going over kind of wave tops on oxygen and ventilators. All right, so supplemental oxygen, again, 88 to 90. So a question came up during break was, well, how do I know if it's a COPD patient that comes into the ER or to my clinic? You may not know. I will say 9 times out of 10, there's going to be a history or it's going to be a very clear, you look at the patient, you're like, you have exactly everything that Mr. Rakowski said. You have a barrel chest, clubbing of the digits, cyanotic, you're a blue bloater, you're having difficulty breathing. Typically, by the time they get to that point where they're having all the symptoms, a lot of times they're going to be on supplemental oxygen. They're going to have a little nasal cannula walking with them. They're going to be on a list of medications, steroids. They're going to start having some of the systemic effects from it. Or the COPD exacerbations. They'll get sent to you, referred to you from like primary care or outlying clinic, an urgent care, nursing home, saying we think this person's having a COPD exacerbation. So that's kind of how you would know. There's a foolproof, this isn't 100%, but typically if you have advanced COPD and you're homeless or you don't have medical care, you're not going to be doing well, you're not long for this world, if that makes sense. So common being common, your COPD exacerbations, typically these aren't untreated patients. These aren't patients that don't know what they have going on. Typically you can put it together, they smell like smoke, they have that nicotine staining, very clear cut. So we talk about devices. I don't necessarily need you to know like the flow rates or FiO2. I want you to understand kind of the escalation of care, right? So just like anything else, if I see an enemy sitting over there on a hilltop, do I call in a nuclear bomb right away? No, I work my way up and see what's going to work, right? So I shoot at them. If that doesn't work, then maybe a direct fire with a mortar or something like that. Then I start moving up, right? So the same thing with these. If I can get away with a nasal cannula, and I don't need a non-rebreather, that's what I'm going with first. I'm going to work my way up. That way I avoid damage or avoid worsening those injuries, and I also conserve my products and medical supplies. So that nasal cannula, 1 to 6 liters. I mean, you can go up higher. You've got the wall device, you can crank it up to 10 or 12, but it's going to be very uncomfortable for the patient because it's 2 little prongs. It's basically like a jet of air hitting them. So we keep that at 1 to 6. And as a general rule for these devices, about every liter of oxygen that you add, it's going to increase the FiO2 by like 3 to 4%, right? So if I give 1 liter nasal cannula or 2 liters, it's going to increase it 1 liter by 3 to 4%. 2 liters is going to be higher than that too. Also kind of depends on that patient's respiratory demand. If they're breathing really fast, it may dilute a little bit. But we work our way down. So face mask, that's simple, right? It just has a tube coming up there and it's a mask that you put on their face. That's going to give you like 40 to 60%. Ones that you seldom see or see less, but I like them a lot, is the Venturi mask, right? So what that is, I'll show you a picture. It's got these little pieces that are colored on there that allow you to actually blend room air with oxygen, so you can get more precise with your oxygen. You can get like 28% or 40% or 60%. Pretty cool device, especially with your COPD patients or your chronic patients. It allows you to fine tune that oxygen so you're not blasting them with 100%. Non-rebreather mask with reservoir bag. So how do we know if that reservoir bag on a non-rebreather is working correctly? Should it completely collapse? So it can partially deflate, but what that reservoir bag is doing is you're basically putting additional oxygen. So if the patient's demand exceeds the supply of that mask, they have additional oxygen in that little reservoir bag so they can breathe off of that. So that's completely collapsed, and that means they're retaining CO2, right? So when you put that patient on a rebreather mask, that bag should not be collapsing completely. Partial collapse is fine. That just means they're pulling off that reserve. But if it's completely collapsing, that's bad. You need to increase the flow rate, okay? So again, just kind of understand the escalation of how you can move up. Nasal cannula is going to be your lowest one, and then down to non-rebreather and mechanical ventilator. If it's on a wall source, we can adjust it up to 100%, and we can fine-tune it. I can do 23% FiO2, 27, whatever I want to do. That's how that works. Then here's examples of it. So nasal cannula, we've all seen these. Now what you may see in your phase 2 sites or other places is they have high-flow nasal cannulas, where it's actually a bigger cannula itself going in there, almost like nasal pillows. You can do a higher flow rate of like 10 to 15 liters. That may be more tolerated by the patient, kind of like a poor man's CPAP almost. But you can also humidify these as well. So plug in your oxygen source to the wall, and then in between it, they have these little humidification devices in there, which may be good for patients. It's more tolerable because it doesn't dry out their noses and give them nosebleeds and make them uncomfortable. Then down here, right, we have our simple mask and our non-rebreather. The mask is identical to these. The difference is down here is your reservoir bag. So here it's just straight oxygen going into them, right? They have no supplement, so if they need more oxygen, you're not getting it. You become a non-rebreather. This bag is a reserve, so basically it fills with oxygen. So if they're taking a deeper breath, they're going to take what's coming being delivered to the mask, and then they're going to breathe off this excess in this bag. So it gives them a little bit extra oomph. Over here is that Venturi mask that I was talking about. So these little pieces, plug and play. If you read the side of them, it'll say, 24%, 28, 31. Inpatient, these are a lot more common because we're getting now more precise. A pediatric patient or a COPD, we're at risk of knocking out our hypoxic drive, so we're trying to walk that fine line. That's where the Venturi mask comes into effect when I'm trying to get precise. And then this is that intubated patient right here. right? This thing down here is actually a humidifier. So air comes out of the ventilator, comes here, passes over that, and it provides additional humidification because medical gas by itself is dry. It'll dry out your patients. Sometimes they may not tolerate it just because of that sensation. It dries out their airways, and they have issues with it. The funniest was when I was a brand new RT at Fort Gordon with these nasal cannulas. We would have these COPD patients. And one of our jobs, pulmonologist would be like, hey, can you take them to the smoke shack to smoke? I'd be like, I guess, sure, it's got COPD, whatever. The patients would come in, they'd be missing their eyebrows. What do you think they're missing their eyebrows from? Well, then, did you take your nasal cannula out while you were smoking? They're like, yeah, and the wife's like, no, he didn't. And then you would see these streaks where the nasal cannula would come out, oxygen would hit it, and it would flare up, and they would be missing the medial aspects of their eyebrows. That's another telltale sign if they're on oxygen, right? When to supplement, right? So, pretty straightforward. Suspected hypoxia, we're coming down here. Risk of hypercapnic respiratory failure. Who are we thinking of that? What kind of patient? Talked about it, right? They're kind of chronically hypercapnic. COPD patients, right? That's kind of who I think about. So if they're at risk for hypercapnic respiratory failure, we're going to be more conservative with our oxygen delivery, and that's where we're going to manage these devices and what we're doing, right? If they're not at risk for it, then we're going to follow this down on the right. What's the special circumstances with CO? Yeah, so that's the one I want you to think about. It's kind of all bets are off. If you're suspecting carbon monoxide, the history matches smoke inhalation. Inhalation, they are in a contained building or contained vehicle, and they've been in there prolonged with smoke coming in. We're thinking carbon monoxide. What am I going to do with that patient? 100%. I'm going to blast them 100% FiO2 with whatever I have. I could do non-rebreather. I could take my ambu bag, crank it up, and just put it over their face and not breathe for them. Whatever I can do to blow off that CO2 or that carbon monoxide. But if they're at risk, right, we talked about that hypercapnia. Don't oversupplement because what's going to happen if I flood them with oxygen? Yeah, I'm going to knock out that respiratory drive, and now they're not going to breathe. And then what you're going to see is that CO2 in their thing, the hemoglobin's going to pick up all that excess oxygen. It's not going to pick up CO2 because it has a higher affinity for oxygen, so all that CO2 goes in the tissues, and it's going to make the hypercapnia worse. So we don't want to do that. So be very conservative with those patients, COPD patients, if you're concerned about hypercapnia. Otherwise, it's straightforward what you're going to follow, right? So if they're at risk, you're going to start them with the lowest one possible. Nasal cannula, 1 to 2 liters. It's going to give about 24%, or if I want to get precise and actually know exactly what I'm doing, I can do that Venturi mask, put the 28% on there or the 24% and go. And I'm just going to titrate my O2 to achieve that range, right? We're going to go down there, bronchodilator if necessary, blah, and then everything over here too, right? So if they're less than 85 and they're not at risk for hypercapnic, so I'm going to go a little bit higher. Either 4 liters nasal cannula, which is going to give me about what? I'd say 3 to 4% for FiO2. What's that ballpark going to put me in? So what's the FiO2 in room air? What are we breathing? 21%. So 4 liters is going to give me what? It give me like 30 to 45, somewhere in that range of FiO2. So you're just kind of figuring that out, 3 to 4% FiO2 for every liter that I give. Pretty straightforward. Intubation and ventilation, right? So indications for intubation. Hypoxia despite supplemental O2. They're apneic or suppressed respiratory function, right? Maybe the paramedics put that COPD patient on a 100% FiO2 non-breather and it was 45 minutes before it arrives at the ER. Would that have been enough time to knock out their hypoxic drive? Yeah, 45 minutes on 100% FiO2 would significantly increase and saturate that oxygen, so now their CO2 just keeps rising, so now they don't have that respiratory function suppressed. Upper airway obstruction, right? Trauma, right? If they can't clear their airway, like we talked about previously, if a patient is trying to sit up after a trauma, they got blood pooling, should you just tell them, like, relax, sit back down? No, they're trying to get into a position of comfort to clear that airway, tripod position or sitting up. So maybe that's indication that they can't maintain their airway anymore. Impaired airway protection, right? Inability to clear secretions. They're so high, so drunk, right? We hear stories about people that are drunk. They pass out, vomit, and what happens? Aspirated. They can't clear it anymore, so you have to protect their airway. And it goes down, they aspirate into the lungs. Progressive respiratory failure. Again, so we're trying to prevent failure. What comes before that? Stress. So if they're progressing and they're not responding to our interventions, we need to be aggressive and consider taking that airway and doing an intubation. So principles of intubation, there's kind of two routes, right? There's a lot of different airways, but the intubation principles is either going to be oral, endotracheal, or nasotracheal intubation. Anybody ever looked at McGill forceps in their airway kit? What are those used for? Those long forceps that are curved. Foreign body retrieval, but they're used for nasal intubations too as well. So you pass it through their nose, you bring it down, and then you take those forceps in the back of the throat, and you guide it down there because you can't use like a bougie or a stylet necessarily. So what would be some patients that would require nasotracheal intubation? What? Okay, you're lucky. Sure. What else? Yeah. You made elective surgeries. Is there any reason why you would do that? Like an oral surgeon who's going to be working in your mouth, can he move that ET tube around and get to stuff? So they may electively do nasal tracheal intubation, so it keeps the mouth open. Who are some people with very large tongues that may be difficult to intubate? Down syndrome, right? So they have abnormally large tongues. You might not be able to, so you may have to nasotracheal intubate. It's really fallen out of favor unless it's clinically indicated because it's very traumatic to the back of their airway. It causes more presentation, more issues with trying to care for that patient. And typically, you can't use as big a tube. So now you're fighting the resistance of the airway because now you're using a smaller ET tube that doesn't match the size of the trachea. So it's not commonly done, but if you ever get to your units or get to like the ER and you're looking at the airway kit, you see these long kind of curved, weird-looking forceps. Realize that's for foreign body removals and for nasotracheal intubation. We're going to be focused on endotracheal intubation because that's the majority of what you're going to do. So in your senior semester, ER will talk to you more about that, and they'll talk about rapid sequence intubation. Right? There's kind of like 3 different intubations you can think about. There's a crash intubation, where that patient shows up, they're not breathing, they have no muscle tone, and you intubate them, right? You give them no meds, you just put it in there. Do we think they have a good outcome? As a general rule, if they don't require some type of paralytic to relax their jaw and relax their muscles, they're not going to have a good outcome if you can just slide an ET tube in there. And we talk about rapid sequence intubation. So rapid, but it's still a deliberate process and kind of rehearsed. And what that's going to be is they come to the ER, they're in respiratory distress or impeding respiratory failure. We need to take their airway sooner than later. But we have a minute or two to kind of do that. So we quickly evaluate our patient, determine our plan. Then I'm going to give some type of sedative, right? Maybe that's ketamine. Then I'm going to give a paralytic that's going to paralyze them, right? That could be fluoxetine, rocuronium, there's a number of meds. You do that, then you get that airway in quickly. And then you kind of have your deliberate intubation, which is pre-surgical, right? You're going in for some type of surgery where they're going to prolong case. Anesthesiologist introduces themselves, talks to you. They look at you, they check your teeth, make sure you don't have any dentures, your Malampati score, they look at everything, they come up with their plan, and then you go to the OR, tell you to put the gas on, what do they tell you to do? Count backwards, right? And it's a very kind of deliberate process. You have control of the situation. So we determine what type of intubation we're going to do, right? Endotracheal, it's either going to be a crash, RSI, or deliberate. Then kind of what we're looking at, part of our plan is what we're going to use, right? So we verify our placement. After we pass that tube, we've done all that. 21 centimeter for females, 23 for male. What is that telling you? Wish I brought ET tube in here. So on your ET tube, right, you're going to have cuffed and uncuffed. Uncuffed are pediatric patients, cuffed meaning adults. So on the side of that tube, it's going to have these radiopaque lines, so you can see it on X-ray, and we'll talk about that. But it's going to have these numbers on here, and that's how deep you go. So if I sink that ET tube, and I just have like the, right here, at the teeth, what's most likely going on with that ET tube? Did I go too far? Yeah, right main stem. And why the right main stem? Hey, there you go, man. So I will say, on your round, like your phase 2 clinicals, you're not gonna just get like an airway rotation or this like that. You kind of have to put yourself out there and hunt after them. So, like for me, example, when I was in phase 2, if I wanted to do intubations, I would go talk to anesthesia and say, hey, can I do a few cases in the morning before my thing? And I did it throughout the year. So that's the only way you're gonna get better at it. So go talk to the CRNAs, anesthesia, and say, hey, do you have any early cases? I have pediatric clinic at 9. Could I come and intubate from like 7 to 8? Or if you're on your surgery or orthopedic rotation, talk to the surgeon and say, hey, sir, ma'am, do you mind if I go over and work with anesthesia for the first part of the case, like before we start the case, so that I can get an intubation in? 9 times out of 10, they're totally cool with it, but nobody's really going to pull you off to the side and say, hey, come take this airway, right? Maybe have it in the ER, but if you want to get good at this, you have to kind of force yourself and put yourself out there. So that's kind of the function of the ET tubes, and we measure that at the teeth, right? Why do we measure at the teeth and not the lips? Lips as well, right? Especially like burn patients, they get that third spacing, things space out. So if I did it initially at the lip and I say, hey, it's at 23, next person comes, change the ship, swelling change, now it may be 25, and they're like, well, it needs to be at 23, so they pull it back or they push it forward. And then now we have the airways moving around. So it's always at the teeth. If they have no teeth, right, if they're meth addicts or they get meth mouth, what do? Yeah, gum line. And then auscultate both lungs and gastrum. Do I get a gastrum or the lungs first? Which one? Who said lungs? So it's very easy to put an ET tube into somebody's esophagus. I'll raise my hand. I've done it numerous times. Anybody who says they haven't are full of shit. I'll just put it out there. There's no perfect intubations. Everybody's got to start at a baseline, right? So if you put it into a stomach and you're trying to auscultate the lungs and that's where you're listening first, what's the other person doing to help you so you can hear? They're bagging, right? So what happens with all that stomach contents, and I just keep pushing air into the stomach? Where's it going to go? I'm not pushing it down into their digestive tract, right? It's going to come least resistance, going to come back up, and then what happens? They aspirate it, and now it goes in their lungs, and now I'm concerned about aspiration pneumonia, potentially ARDS. So always listen to their stomach first, right? You want to hear that gurgle sound, and then listen to their lungs. Another thing we can do is CO2 detector, right? This is waveform capnography. There's also color capnography. It's like a disposable device that you put on the end of there. You can put it at the end of the ET tube between the ambu bag, and that's going to change in color. So gold being good. If it changes from the color to gold, that means you're getting return of CO2, you're in the lungs. If it stays purple, that's poor, that means you're in the stomach, you're not doing anything, right? Waveform capnography, right? What's another name for that? Entitled CO2, which should that level be? Yeah, and what is our CO2 on ABG? Yeah, it's easy to remember, right? So entitled CO2. Those are becoming more popular. Those are pretty much standard in every anesthesia, OR, ER in the United States now, and they're becoming standard in pre-hospital medicine as well. So paramedics will have those. Chest X-ray, right? That is going to show us that we're actually at the right location and that we haven't gone too far or we're too high up. We want 5 centimeters above the cranium. So what's going to happen is when you're on your rotations, you have an inpatient, right? You're going to round on your patient as a team. You guys are going to be expected to pre-round, which means you get there half an hour early before the attending, before the formal process. You go check your patients. So if they're intubated, a lot of places every morning they're going to get a chest X-ray to see if there's any changes. And then you're going to check ET tube placement. So you're going to look at the ET tube, see if it's still at 23 teeth, as noted. Is it causing any oral trauma? Is it doing it? Or do a quick exam to make sure like the things aren't cutting into their mouth, and get a chest X-ray to check to make sure that ET tube hasn't moved. So kind of a rule that we used to use is the nose or the hose follows the nose. Anybody ever heard that? So meaning if I move my nose up, what's going to happen with my tube? It's going to come up too. So if I move my nose down, what happens to that tube? It pushes it down. So look at your patient's position. The hose follows the nose, right? So if they're sitting in this position like this, that may actually extubate the patient or pull it up higher, where now I'm not getting a good gas exchange, that seal with the cuff on there. If I go down too far, they're kind of like sitting in this position like Stephen Hawking, right? The nose is down, Then it's gonna push it, it may push it right main stem, okay? So, hose follows the nose. Here's an example of oral endotracheal intubation, right? So what is this thing right here? This B. Yeah, so that's your cuff right here, where you can inject air, and it comes down here, there's another tube, and it follows down here, and this would actually inflates it, allows you to get a good air seal on there. Can you overinflate these? Yeah, so if you just jam like 20 cc's of air in there, what's gonna happen, it's gonna constrict that, and it's gonna cause tissue necrosis on the inside of the airway, right? So they have little manometers that you can use to determine if it's appropriate. This is where you hook up your ventilator, your ambu bag, like A, right? And then what is this little guy right here? This little thing.
Vocal cords.
Vocal cords. So when you're doing your intubation, you want to verbalize it so everybody hears you. Like, I visualize the vocal cords. I'm passing through the vocal cords, right? Your senior semester, we'll do round robin. And you guys will get to use the different types of laryngoscope blades. There's a Miller and a Mac. Miller is your straight one, L. Mac is a C, so it's a curved blade. There's different sizes of them. And then you'll also have the glide scopes, which is that cool little laryngoscope, and it has a video camera on it so everybody can see. Army guys don't get used to that. Like, they don't give you the nice stuff in conventional Army. Then down here, this is an example of nasotracheal intubation. What does that person do with their other hand? Yeah, so they're pushing down on the cricoid membrane, and what that's going to do is it opens up the vocal cords, makes it easier to visualize. So in this case, if you were doing it this way, you would put your McGill forceps in their mouth, grab that tube back here, and then you would direct it anteriorly, right? So the esophagus is posterior, vocal cords are anterior to the trachea. Another thing you can do is put a bougie in there, and you'll feel these cartilage rings when you're passing your bougie through. Then down here, this is what we're looking for on our chest x-ray, is this radiopaque line, right? So you'll be able to see that clearly on the x-ray. How you know at the end is the same thing with the chest tube. Typically, these are a little bit different, but a lot of times they'll have a break in the continuation of the radiopaque line so that you know you're at Murphy's eye, which is that final portion on there. And this is how we look at it, right? So looking to find my crine, or right here, it bifurcates, and then my ET tube is this radiopaque line right here, kind of overdone, you can see, and then crine is down here, so 5 centimeters. How do you measure that? Well, your tape measure now. So you'll pull a tape measure on the x-ray itself, the digital ones, it'll have like a little tool that looks like a ruler, and you can measure that, right? So you're gonna move the ET tube, get somebody to help you out. It's one of those things, holding it and then trying to retape it and do everything becomes a pain in the butt, and then you'll inadvertently extubate patients accidentally. Again, I'll be the first one to meet. Have I ever accidentally extubated a patient? Yes, I've done it a handful of times, probably both hands, if I'm being honest. I mean, it happens, especially in certain circumstances, environments, or if you're working by yourself. And then right here, is this a late finding or early finding? That they are right main stem. Early? Are you sure about that? What's going on with that left lung?
They don't have it.
So this is a late finding. You're starting to see it push over right here. So there's nothing going on. I don't see any vasculature. So it's going in through here. Sometimes would you need to purposely do a right main stem? Yeah, if you're doing surgery on the opposite side, they may purposely intubate that side, the left or right main stem, so that they can deflate that lung so they can work on that side. There's certain operations, or like I said, they may just have already had a lungectomy and had that lung removed, and you're that person who puts in the chart clear auscultation bilaterally, and then you kind of have to be the one who gets made fun of at rounds because you put bilaterally when they only have one lung, right? So look at your patient's history ahead of time before you do that. Tube migration, right, main stem, we talked about that. How do you remember if that tube's going up? It follows what? The hose follows the nose, right? So pro tip, recheck that every time you move a patient, right? Anytime you move a patient, what's the thing that we teach medics? recheck all your interventions, right? Stuff likes to come loose. If they have a tourniquet on, you move the patient, recheck that tourniquet. If they have an IV, recheck it every time you move your patient. Barotrauma, right? Positive pressure set too high. We're causing pneumos, or may create ruptured blebs, right? We're overinflating the lungs. Evidenced by pneumothorax. What's a pneumomediastinum? Amen, my man, right there. Air in the mediastinum, right? So it's that air between the lungs and the center of the chest. Typically, this responds pretty well as long as it's not too big of air. It will self-absorb. Sub-Q emphysema is another possibility. So, I always want to use the lowest pressure, tidal volume, and respiratory rate that I can to prevent barotrauma. So if I can get away with a 500 ml tidal volume and I don't need 600, I want to do that because the higher the tidal volume, the more likely I am to cause barotrauma. Then straightforward, right? You guys should never miss these on any test because you know the pathophysiology and how it works, right? If I breathe too much, too fast, or too deep a breath, what happens to my CO2? Drives it down, right? Straightforward. If I breathe not enough or too small a breaths, what happens to my pH or to my CO2? Goes up, right? So what happens if my CO2 goes up? What happens to my pH? Goes down, right? So again, it's just too large a tidal volume or too fast a rate, or it's too small, too slow. Hypotension, right? This is a concern. So basically, the chest is just so big, right? It only fits so much stuff in there. So if I increase the pressure and tidal volume and I give them a high peak, putting pressure in the chest, which is then putting pressure on what other structures? The heart, what else? You're gonna put pressure on any of the vasculature, vena cava, right? So that could start causing pressure with my heart because now they can't return blood to the heart. The heart has to work harder. So back in the day, we used to give PEEP, right? PEEP is that post-positive index expiratory pressure. We usually start at 5, keep the alveoli open. But if we're having difficulties with oxygenation, we may increase it, right? Back in the day, the old school pulmonologists, we would go up to like 30 or 40 on PEEP in some patients. Nowadays, if you did that, everybody would be like, you're a maniac, you get malpractice and everything else like that. But we didn't have a lot of tools, so we used what was available to us to help with the alveoli. So remember, hypotension, if the pressure gets too high in the chest, too much volume, that can start putting pressure on the vasculature, the heart, and make it work harder. Ventilator-associated pneumonia, what kind of pneumonia is that? Does it fall under CAP or HAP? HAP, right? And that's at 48 hours after intubation. Most likely that's a poor technique. It was done dirty. We introduced something with our laryngoscope or our ET tube or whatever device. The use of sock surgeon, old surgeon, Jim Zarnick, great guy. Everybody's ever met him, gives you a hug. He's an ER doctor. He used to keep a bougie, which is this long flexible tubing that you help with intubation. He put it into his scrubs, where like the cloth goes in there, and whenever there's intubation, you would pull it out, ready to go. You're like, cool, man, you're ready, but that's fucking filthy and disgusting. You just pull that out of there, right? So would that potentially cause introduce an infection into their lungs? Yeah, so VAP, ventilator-associated pneumonia, can be associated with that intubation and a number of things. All right, so that was that previous x-ray, right, that we talked about, where its right main symptoms migrated. And then everybody's seen that radiopaque line that I was talking about. It's this solid line right here. So this is your ET tube, this guy right here, that white line. What is this line? Yeah, just a chest lead for that. So that straight line that's going up and down, that is your ET tube, that radiopaque line that you're going to check. Right? This is your ET tube, which is just like a cardiac lead monitor. And then you see that pneumomediastinum over there, right? So is that air around the heart, or where is that air? Is it in the pericardium? Oh, so it's between the pericardium and the lung. So you see it follows the contours and it's pushing that lung away. So unless it's a giant pneumomediastinum, they're typically not going to cause a lot of issues for the patient, and they're going to resolve on their own as long as you identify it sooner than later. But a large enough pneumomediastinum almost causes like a pneumothorax, where it starts compressing that lung, but it's coming from a different direction, coming from the medial aspect and pressing that against the chest wall. The basic ventilator settings. Again, this is like very wave tops on this. There's dozens of different ventilator modes and different. There's always additional stuff. This is the basics. that if you can memorize these and talk about these intelligently, you'll come to keep your head above water. So this is volume ventilation. So we can kind of do ventilation two different ways. We're talking about positive pressure ventilation. I'm forcing air into somebody's lungs. You have volume and pressure, right? So I can either set a tidal volume, that's how big the breath is, right? And that's mLs, so like 500, 600, whatever you want to say. I could also do pressure, where for some ventilators, it's going to be pressure set. So I'll set like a pressure of 50, and whenever the ventilator hits that pressure, it's going to stop breathing for them. But we're going to be talking about tidal volume. Respiratory rate, pretty straightforward rate, 12 to 16. You can play around with these because these are going to determine what? Tidal volume and CO2, how big the breath is, and how quickly I'm breathing. So what's that going to affect? CO2, right? So remember that. So tidal volume, respiratory rate, or what's going to dictate your CO2, that's how you're blowing it off. So it's either big breath, small breath, breathing fast, breathing slow. FiO2, we've kind of beat to death, right? It starts at 0.21, that's room air, and it goes up to 100, right? The lower the tidal, I want to set this as low as possible. So if I can get away with 21%, cool, I'm going to use that. If I need to increase it a little bit, I'm going to go slowly in increments, right? Unless I'm having like an acute desaturation where I'm looking at the patient, the sats just drop, I may do 100% temporarily for a minute or two, and then go back down to the previous setting to see if that improves. Then we have PEEP. That's that positive pressure at the end of the breath. So instead of a 0 baseline pressure, now I'm increasing it. So 5, 10, 20. Too high a PEEP can do what to the patient? Pop their lungs, because I'm doing it, it can cause barotrauma, right? That previous slide. Too high of PEEP. Now I'm putting pressure on there. What other physiological effects could it cause? What could it do to their blood pressure? Hypotension, right? It's putting more pressure on there. It's not, the heart is not able to actually get blood out to the tissue because it's working harder. You're going to see that more and more with a patient with comorbidity. If they have some underlying heart disease, heart failure, it's going to be more pronounced and sooner. And then the two modes, primarily we're going to be talking about is control and assist, and when we talk about that here in a second, it'll make more sense. So control, the ventilator initiates each breath to control rate, volume, everything else. So that can be an issue if the patient's spontaneously breathing, because the ventilator is going to keep giving breaths, right? So if the ventilator and the patient are both trying to breathe at the same time, what happens? They're unsynchronized, right? It's like me and my wife trying to dance. She won't follow, and I'm trying to do it, and then she's stepping on my feet, and it just looks bad. Because I'm a good dancer. Y'all know that. Wife, not so much. So control breath is the ventilator doing that. Assist breath. So what that is the patient initiates the breath. They take in a deep breath, that negative inspiratory force. The ventilator determines that. It senses that they're taking a breath in, and then it kicks in and delivers the rest of that breath to make sure it gets a certain tidal volume. Right? And remember, the two things that control oxygenation are FiO2 PEEP, so the amount of oxygen and that post pressure to keep the alveoli open. CO2 is going to be controlled by tidal volume and respiratory rate. So assist control ventilation, right? Most of like our transport or pre-hospital vents are going to be in this mode. They're preset for that. So what it is patient triggers a breath, which you see right here. This is your baseline, right here, this dark line. So we'll say that's 0. Patient takes a deep breath in, it goes negative because they're drawing air in. Ventilator detects it, and it gives the rest of the breath, meaning it's going to be uniform and equal throughout it. So it's going to give that preset tidal volume of whatever you set it at. So no matter how hard the patient breathes in or does, the ventilator is going to trigger it and stop it. So it's going to say it's set at 500, and then it's going to shut off. It has a little valve. It's going to collapse, and the patient can't breathe any more than that. And right here, in this third one, there's no inspiratory effort by the patient. So the machine detects that the patient hasn't breathed in X amount of time, whatever you set it at, 2 to 3 seconds, and it's going to deliver a breath. So this mode is good for giving uniform breaths. It's going to be a little bit more difficult to take your patient off the ventilator because the machine is doing the majority of the work for them, right? It's delivering that tidal volume, so the patient's not using the full inspiratory, expiratory effect to do that. SIMV is another more popular mode. Not more popular, but it's another popular mode that you're going to see. A lot of like basic ventilators are going to have assist control or SIMV, and you kind of make the decision on there. Both are safe. SIMV, what the benefit of this is, is the machine's always gonna give breaths if the patient's not breathing, right? It's smarter than us. So it's gonna detect apnea, the patient hasn't breathed in 3 to 5 seconds, whatever you set it at, and it's gonna give breaths. But what it does allow the patient to do is breathe on their own. And so the breaths may not be uniform like they were here. All these are exactly the same. On this one, it's gonna allow the patient to breathe. So the benefits of this is if we're trying to wean our patient off the ventilator, basically because we can't do cold turkey, you just take them off there and then throw them to the wolves and be like, all right, breathe. They may have lost that respiratory effort, their muscles, right, while they've been in the hospital. So we want to wean them off of it. This tool allows us to allow them to breathe. And then there's other tools that we can use to actually make sure those breaths get bigger and bigger so they're using those respiratory muscles. So again, this is great for breathing, for when the patient's recovering and we're trying to wean them off the ventilator. SIMV, that's the benefits of it. The patient's doing more of the work. It just may not be as uniform, it's not as pretty. Again, that's just basically what we talked about it. SIV is usually better tolerated because the patient's allowed to breathe on their own. Assist control, you may have to increase sedation because if the patient's breathing very rapidly, what's that machine doing every time it detects breath in assist control? It's going to give that full tidal volume. So if they're tachypnic, right, breathing like over 20, it's going to give them a full tidal volume each time they trigger a breath. So a patient may not tolerate that very well. It may cause more barotrauma because now you're stacking breaths on your patient, giving them full tidal volumes. At that rate, they're not able to off gas. All right, any questions? All right.